Okay, Ahmed, just go and start, Ahmed. Your first one came here. Want to start?
All right. A 56-year-old male visited an emergency department with a sudden onset severe abdominal pain.
Okay.
Abdominal pain developed 4 days prior, and he had been hospitalized at another hospital. The abdominal pain was severe, numeric rating 8 out of 10, and induced steady epigastric pain that had lasted for 5 hours before painkiller administration at the hospital. Thereafter, he suffered from epigastric discomfort, in particular after meals. He was a social drinker and quit smoking 4 years prior after 30 years of cigarette smoking. There was no recent history of peptic ulcer symptoms, heavy alcohol drinking, blunt abdominal trauma, arrhythmia, or past history of abdominal surgery, or aortic angiography. Vital signs at the time of initial presentation were blood pressure of 135/93, not on antihypertensive medications, pulse rate of 73 per minute, respiratory rate of 20 per minute, and body temperature of 38.1. On physical exam, there was no evidence of jaundice, and the abdomen was soft and not distended with mild tenderness at the epigastrium. Blood test shows no abnormalities in cardiac, serum bilirubin, amylase, lipase, and serum electrolytes except leukocytosis, 15.5, segment of 83%, and increased C-reactive protein levels, 18. Urine analysis, chest X-ray, and echocardiography were unremarkable. Plain abdominal X-ray was unremarkable except fluid, segmented dilatation of small bowel.
Okay. So what happened? How old is he, Mrs. Patient? How old is he?
He is a 61-year-old with symptoms of mesenteric angina.
Angina? Why angina? Why?
The pain is mostly after meals. Other symptoms of peptic ulcer disease were absent.
But the pain is very severe, 8 of 10. Does angina give you 8 of
10? It's usually out of a proportion to the examination.
So out of proportion, not angina, what do you call it? You're right. That, not angina. Ischemia, right?
Oh, ischemia, sorry, yeah. Sorry.
Ischemia is typical. You see severe pain and with minimal fighting, because when you have a severe pain, you have to fight something, irritation, if you have a pancreatitis, bowel perforation, anything you see as symptoms, very tenderness, lab changes here, everything's fine. So when patient comes with severe pain, not to say moderate, it's 8 of 10. So patient comes with severe pain with a minimum abdominal finding, this is about ischemia until proven otherwise, okay? So this is typical patient with ischemic bowel, correct?
Yep.
Yeah, because you see, just severe pain, you don't find anything, So, okay. Because amylase lipase is normal, bilirubin is normal, everything is normal to think about it, no peptic ulcer disease, nothing like that. And again, the most important, the physical exam is almost very mild tenderness, not much impressive, All right, so let's go to this is X-ray. Also, X-ray doesn't show much, just some ileus here. You see some ileus?
Yes.
So nothing much you see in the X-ray. So it's a question one. I know I was able to answer, so I have to cover them, really. Okay, so let's go with one.
What other diagnostic modality would you recommend to help make diagnosis for this patient?
Okay,
let's begin them one by one. Gastric endoscopy, it will not help in diagnose, but rule out peptic ulcer disease.
Okay.
Colonoscopy is the same for the colon. It might show gangrenous bowel.
But I'm saying you are in the ER now. And patient come with this one. What are you going to do next?
None of this. I will do straightforward to CT.
Correct. So you get a CT scan to see what's going on, of course, with the contrast, okay?
Yeah.
Other things, gastroendoscopy, colonoscopy, all the things I don't think will help, Unless if the CAT scan is negative, I don't see anything there. Maybe peptic ulcer disease, maybe gastritis, then we'll do this one, okay? But first, I will get an order CAT scan because I'm thinking about bowel ischemia. And if you're bowel ischemia, you can see something on the CAT scan,
Yeah, true.
So this will be, our first approach. Okay, let's move to somebody else. Yes, enough. Muhammad, you want to take Muhammad, the man?
Yes, doctor.
Okay.
So an initial contrast enhanced CT scan was obtained at other hospital. We found a long narrowing of proximal SMA and
Mhm.
occlusion of mid SMA.
Mhm.
At the hospital, the patient was treated with fasting, IV fluid, anticoagulation with intravenous heparin and antibiotic, ceftriaxone and metronidazole. After 3 days of fasting and medical treatment, abdominal pain markedly improved and the patient was allowed to intake fluid.
Okay, let's see the CAT scan. This is a CAT scan here. What do you see in CAT scan?
Yeah, I see as he mentioned, stenosis long segment,
Hmm?
then occluded part for, yeah, then he has occlusion also in this SMA, and then with reconstitution, I think, down.
Okay, so what do you think is the cause of that?
So this picture mainly showed acute on top of chronic ischemia, maybe. Yeah, he has part of chronic stenosis and maybe thrombosed over that.
Okay, but two things. First, I mean, he has no history of abdominal angina before. If you remember back
Yeah.
to history, he was
Yeah.
sudden. He has no history of weight loss, no history of abdominal angina before. Because otherwise, he will tell them he came to the ER suddenly severe pain. So we
Yeah.
think about bowel ischemia. Bowel ischemia, either you think was emboli, thrombus,
Yeah.
which we see here. I mean, this study, you see that thrombus.
Yeah,
But
you
is
can.
that SMA doesn't look right. You see like two lumen, and you can see some like thrombose, and one is
Yeah.
open.
Maybe
The
dissected.
second one was dissection.
Dissection. Yeah,
It was more
dissection. صح.
dissection. It's acute dissection. See. Again, I mean, if he has a symptom before, yes, I agree with you. It goes like long chronic, but he has no symptom.
Yeah, yeah.
You have to presume that. I mean, what confuses us in the false lumen thrombose, usually you see two lumen, you see double lumen in CT scan with dissection. But here is the way it looks like he has a dissection and he thrombosed the false lumen. And the distal, but the good thing, and he has like thrombus because the false lumen compressing the true lumen called occlusion, but you get good distal runoff. So it still has a runoff distally, The reason why they did it conservatively, because if there's no flow, then you have to take him to surgery. But here, I mean, he is doing fine because, I mean, it was dissection, always like our dissection, always try with the conservative management, unless he has a sign of bowel ischemia, If you look at the bowel of the CAT scan, I don't see any thickening in the bowel. The bowel looks fine. He sees a wall.
Yeah, it looks normal.
Yeah, it looks normal. Here is no free air like perforation, no free under diaphragm. So we have no sign he already has an ischemic bowel. So most probably he has an acute ischemia from dissection caused that, So you have a space for medical measurement, to see if they improve like any dissections, Of course, you have to watch them. If you get worse anytime, then you have to interfere,
Yeah.
Well, let's see what they give you, what this question is. So question. So what condition do you suspect? Go ahead.
Yeah, what condition do you suspect most likely the cause of long segment narrowing and occlusion of the SMA? As we mentioned,
dissection.
Dissection, yeah.
Right.
But
right.
it's very rare to see an isolated SMA dissection.
Yeah, it's right. That's why I brought this case, and we have, I don't know if you was in the case discussion group, we discussed similar like a couple of days ago. We have a big dissection, and this was a big discussion about it,
Yeah, I know him. I know the patient.
I
know the patient.
Yeah, so this was a similar case. You get a dissection. It's very important to see what caused that and how we treat it. If you have a chronic and acute, usually you see thrombosis at the origin. I don't think you see thrombosis distal. Distal you see as emboli. So this acute and chronic, there must be you see the origin is thrombosed,
Yeah.
You don't see like this one long segment stenosis and then distal occlusion. So this is really, again, go with more dissections, All right. So, but Sam, you want to take next one? Ask a question, quick question today. Yeah.
Okay. Which one is not correct regarding clinical features of SMA dissection? A most common clinical feature is sudden onset of severe abdominal pain.
Yeah, it's dissection like this one. So this is the most common. Presents a severe abdominal pain. This is a sign. I mean, sometimes you can find it incidentally, you know. Find this. Why is that? Because most of he has abdominal pain, and then most of the times they recover by themselves, and then he get better by time, and he just ignore it.
Yeah.
So otherwise, very rare to see dissection without any symptoms, and he had an old dissection. And because abdominal pain is very common, so a lot of people, they get severe abdominal pain, they get rest, you know, for 2 or 3 days before they go to the hospital, and they improve, so they just ignore it. And then you do a CAT scan later on, you'll be surprised to find a dissection, you know. Okay, but usually when dissection happen, you have to have a severe abdominal pain, like thoracic dissection, intubation. Sometimes we see incidental finding, but it never be incidental. Also, we talk to the patient, said, yeah, a couple of years I have severe chest pain, but by itself, you know. So this is what happened.
Mm-hmm. Okay, so the question is, which one is not correct?
Correct. The first one is correct.
First one is correct.
Okay. Second one.
Second one, symptom may be subtle. So,
Yeah.
Also it's correct.
Correct. Okay.
Abdominal pain usually subsides after fasting for a few days. Also, it's correct.
Correct. This is the way we treat it usually.
Yeah.
The patient comes with a severe abdominal pain to the ER, have a dissection. There's no sign of ischemia. Is restricted and conservative with fasting and anticoagulant, you know.
Yeah.
All right.
More prevalent in female patients. I'm not sure, but I think also maybe this is the answer. Maybe.
Correct. It is. It is. If you don't know, look at the last one, and then if the only one left, you can pick up this.
Yeah, last one is correct. So I think D is the answer.
Yeah, I mean.
So yeah, E. So the risk of bowel gangrene is very low. Abdominal pain may persist a week or longer. This is also correct. So D is the answer probably.
Yeah, this is correct. I mean, it is more common in the males, especially like around 50 years old. Risk of bowel gangrene is very low. That's the reason why you can try conservative management. It's different from emboli, you know.
Yeah.
Always we try conservative management. Again, it may take a week or 10 days for the pain resolve, but you just watch him, you follow up his lab, you know, you follow his symptoms, and you decide that, you know. You follow up his lactic acid. If any sign you see, like sign of bowel ischemia, you have intervened. But luckily, as I said, majority of the patients, they don't go to bowel ischemia, you know.
Yeah.
So the good thing about dissection. And the reason why you don't go back to bowel ischemia, because most of the time you have like a thoracic dissection, you have an entry and you have an out exit. The blood go in and out, so you still get flow to the bowel, you know, even we have a dissection. And most of the time you see SMAs open. Rarely you see SMAs open with a dissection.
Yes.
All right, so this is the nature of history. Okay. Who was Zahra? Want to take this one? Number 4.
Yes, Doctor.
Okay, Zahra.
What is the most likely underlying cause of spontaneous dissection, SMA dissection? Hypertension, smoking, hyperlipidemia.
So what do we? Sorry, put the rest. So do we know what the cause of dissection? Small bowel dissection.
Connective tissue disease and none but anatomy of SMA may attribute to the development of spontaneous SMA dissection.
So the question is that, yeah, go ahead.
Is connective tissue disease. The most common, can we see? Yeah, the most likely cause.
Okay. I mean, really, nobody knows.
Connective tissue disease. Yeah, nobody. Okay.
I mean, what?
But because
really,
it's spontaneous and not associated with the other dissection.
Usually it is spontaneous. I'm talking about spontaneous SMA occlusion alone. We're not talking about, you know, type B dissection spreading to the SMA. We're talking about isolated spontaneous SMA dissection? Nobody knows. We think that like an aortic dissection could be hypertension, smoking, hyperlipidemia, connective tissue disease, all are theory, you know, but nobody knows really for sure what caused that, you know. But like hypertension usually is not very common. It's not like the thoracic dissection, 90% above they have a hypertension. And the SMA dissection, only maybe like 20-30% they have a hypertension. So it's not like the same as the thoracic dissection. Smoking is a risk factor, hyperlipidemia is a risk factor, but it's not really 100% confirmed. Connective tissue disease, yes, but again, we don't see it quite often with a spontaneous SMA dissection. Like if you see only spontaneous SMA dissection, you don't go and start investigate for connective tissue disease, different from type B dissection. You see my point? So nobody really knows the cause. This is theory, they said here, the last one, because they think the SM8 has two parts. Part is behind the abacus, which is fixed, and we have part intra-abdominal, which is the distal part, which is mobile. Become like subclavian artery, you know? So you have a shear stress is different between the proximal distal part of the SMA. So they feel that the different stress shear can cause the dissection, but all is theory. So in general, nobody knows. But the only thing you have to know is that the risk factor for isolated spontaneous SMA dissection is not the same as type B dissection, okay? Maybe this is the only message you can take from this question.
Okay.
Okay. Well, let's go back to question 5. Who's with us? Come on. Muhammad, you want to take it, Muhammad?
Sure, doctor. Which one is correct regarding the optimal management of spontaneous SMA dissection? Most of spontaneous SMA dissection patients eventually require SMA intervention.
Okay.
B, open surgical treatment is better than endovascular treatment in terms of outcome.
Okay, let's continue.
C, in most cases, exploratory laparotomy is recommended to confirm bowel gangrene.
Okay.
D, most of patients with spontaneous dissection can be conservatively managed, while SMA intervention is considered only for selected patients. E, antithrombotic therapy, including anticoagulant or antiplatelet, is required for all cases of spontaneous SMA dissection.
Okay. Well, let's start one by one.
Bye.
Okay. So most eventually required SMA intervention. This is not correct.
Yeah.
Because most of them, they will just like, if you see patient with SMA dissection, what we do, I mean, in our clinic, just conservative.
Yeah, conservative, unless it's very symptomatic.
So intervention, when we do intervention?
If the patient is very symptomatic,
correct,
in terms of abdominal pain or any signs of bowel gangrene in the labs or CT.
Correct. I mean, if so, I mean, the only time we do intervention, if he has not symptoms, no pain, usually will resolve. But if it's like 3-4 days, he still have severe pain, like an aortic dissection, then we have to stent him. Okay. If any sign of bowel ischemia, then you have to stent him. Okay.
Yeah.
So
and if he developed aneurysmal dilatation, we'll treat him as aneurysm.
No, this one we don't know, and nobody knows the answer for this one. Don't know. Because they progress to aneurysm, yes, but we don't know what size we need to treat. You have to be watched. If the aneurysm is increasing, yes, you have to be fixed. But the problem, we don't have any guidelines to tell us what size we need to. You cannot apply the SMA aneurysm. You see, if you go to the American guidelines, what size you fix the SMA aneurysm? American guidelines.
2.5 centimeters.
2.5, this is the European.
Yeah.
American, they said any size SMA aneurysm has to be fixed. But this is American, you know?
Yeah.
European said 2.5, you know. But again, you cannot apply this criteria here because dissection is like the same, like in type B dissection, we said if you have an aneurysm 4 centimeters, you fix it, right? In the type B dissection, if you have 4 through more than 4, we fix it, right?
Yes.
In a normal aneurysm, we don't fix it until like 6 in the thoracic.
Yeah.
So it's different. And here, exactly the same. You cannot apply guideline from SMA aneurysm to the dissection. And unfortunately, we don't have a guidelines. So nobody knows. But in general, people like to be conservative. So if you find an aneurysm, we just watch it. If I see increase of size of aneurysms, then I may treat it. If the aneurysm is stable, I will just watch it, okay? This is, and luckily the majority will not require interventions, you know? Now the question comes, should we do an open or endovascular? Which one is better, you know? Again, this one go back to the type B dissection. It's very similar. Type B dissection, which one is better?
Endovascular.
Correct. And why? Because dissection is different from aneurysm. The artery is very thin, difficult surgery, and the same here. Dissection SMA, the artery is very thin. If you go to do a surgery, it becomes very complicated because sometimes it just tear apart when you suture it, you know? So always our first approach is endovascular. If the endovascular failed or you cannot do it, and we have to do a surgery, or you have to fix it, then you have to do a surgery, okay? What type of surgery? We have 3 types of surgery you can deal with that. First one, you can open the artery, take the intima between, the intima between cause dissection, okay? And you can put a patch there. The other option, you can resect the segment and put a vein, interposition graft. Or the third option, you just get a bypass from the aorta to the distal SMA, okay? But what the problem was this surgery, why surgery is so difficult? Because it's difficult to get a control because the dissection starts exactly usually at the aorta. So you have to really control the aorta. And this is difficult because it's a celiac, you know, SMA, you know, and you know, it's very difficult to control SMA in this aorta in this area because of retropancreatic, you know, so you have to go to supraceliac and all the things. So surgery is not really easy as you expected, you know. So we don't like to do surgery unless in extreme cases and whereas, you know, endovascular that has no option or failed, you know. But treatment first and conservative. If you have to do something, you do endovascular. If you cannot do it, then open repair. And again, open and repair, you have to be very careful, but the easiest way is to put the position graft or just forget ligata proximal and do bypass from the ascending aorta to the distal SMA. Okay? Is it clear? Any question about this part?
Clear.
Okay. So let's go back to next. C, in most cases,
exploratory laparotomy is recommended to confirm the bowel gangrene. I think wrong.
this is
We
wrong
have
because
CT now. Nowadays is very good for diagnosing the bowel gangrene.
next one, E, most patients.
Most patients can be conservatively managed with SMA. Intervention is considered only for selected cases. I think yes, this is correct.
So this is what, so most of them, we can only select a patient, you know, again, if they have persistent pain, they have, you know, symptoms, very narrow, distal true lumen very compressed, and you're getting severe abdominal pain, which is not resolving, then you have to do something, you know, but they have to be symptomatic. But somebody called you, they found incidental finding on CAT scan, SMA dissection, nothing, okay? So the next question, which is important, should give anticoagulant or not? Is a tricky question.
Problem is he mentioned antiplatelet. I know aspirin is indicated, but I'm not sure if it's anticoagulation is the same group as antiplatelet in this kind of patient.
It depends. Like this patient, you know, when the one who came with the thrombosis and compressed lumen, you know, I'm going to watch him. Usually I put anticoagulant, you know, put heparin until this resolve or his pain resolves, because he has severe pain, has dissection, he has a clot distally, you know, and he compressed through lumen, then yes, I'll treat him with anticoagulant, you know. but patient is a true and false domain, both open, just dissection. There's no clot. They did the study. They compare anticoagulant without anticoagulant, and follow-up this patient is no different. So there's no indication. So if you find patient incidental finding CAT scan, he has a dissection, he's asymptomatic, we just leave him alone. We don't even give anticoagulant or antiplatelets, okay? Sometimes antiplatelets could be sometimes risky because can cause bleeding, and this can, cause more, compression of the true lumen. So in general, we not recommend anticoagulant unless if we patient compromise flow to the bowel. Again, severe compressed true lumen, thrombus in the end. We worry about the bowel ischemia, like this patient come acute ischemia, but we just give him anticoagulant until they go home. Maybe when they go home, we give him like for a month or so until get remodeling. But patient asymptomatic, his pain resolved, with no pain, nothing, we don't give anything. Okay? Any question? Because this is the most important slide of the treatment. This is where the controversy. Again, we're talking about aneurysm. If you get an aneurysm, again, nobody has an answer, but most people, they just watch it for now. And then we watch if it's increasing in size, then yes, to treat it. The question, what to treat it? The problem is that if you use a cover stent, then most of the people you can cover a major side branches because a lot of branches come from SMA. So if you put a cover stent, you may compromise flow. So this is the issue with the aneurysm. So you have to be careful with that. If a young patient, maybe better to do a surgery, But again, you have to weigh risk and benefit. But don't treat unless if really you have to do it, unless the patient's symptomatic. All right, Ahmed, we can go back to you, Ahmed.
Yes, please.
Okay.
How often does the abdominal symptom recur after pain resolution by conservative treatment for symptomatic patients with spontaneous SMA dissection?
You just have, yeah, go ahead.
Almost all. The word all concerns me. I wouldn't choose it.
Right. So in general, how often they come back with the pain? They have a pain, and how often they come back with the pain? Not many. Why? Because the reason why you said most of a dissection we see incidental. So what happens? They have a pain one time in their life and then never came back. So the majority will not have pain again. The reason why we don't discover it, most of the time it's covered incidentally, So I will go with the low number. Most of it, I think most people, they say about 20%, The majority, they don't have it. Just one time they get dissection, you treat them conservatively, and you have no more pain, So this will be the answer. Continue with that, please.
Okay, 2 months after the hospital discharge, the patient developed recurrent abdominal pain and vomiting.
Okay.
Follow-up abdominal CT angiography showed recanalization of the occluded segment of the SMA.
Okay.
The recurrent abdominal pain was resolved after 3 days of conservative treatment management. Thereafter, during the follow-up period of 42 months, there was no episode of recurrent abdominal symptoms. On the follow-up CT images, the SMA dissection lesion showed remodeling with minimal residual narrowing.
Let's see that. You see it now, how it's occluded now here?
Completely occluded.
And now look at that, it looks beautiful. This is the reason why conservative maintenance work beautiful, Just give them time, don't rush for stenting, don't rush for anything, And you see how many branches coming from the SMA? So if you go and put a stent cover, for aneurysm, if dissection, you don't have to put uncovered stent. If you have to treat dissection, I'll maybe just put uncovered stent, self-expandable uncovered stent, because I just want to tag, the dissection and open the true lumen. But if the aneurysm, you have to use a cover stent, is a problem, because all these branches here coming out.
Collaterals.
But you see how much is they remodel very nice. You just be patient, follow up this patient, and majority they will be fine. All right. So what's the question now? Let me see what the question. So this is number 7. What's the question? Go ahead.
Okay. Following are indications for primary interventional treatment for symptomatic dissection. Which of the following is not correct? Prolonged and relieved abdominal pain should be an indication.
Primary intervention. Prolonged and relief abdominal pain, yes. You have to,
Yeah,
if it's like,
should
but
be
you
an
have to
indication.
be patient. Don't 2-3 days. You say we said week 7 to 10 days. 7-10 days you don't see it, then we have to worry about it. Okay.
Okay.
Next one.
Symptomatic patient with short life expectancy due to coexisting disease. No, they shouldn't be a candidate.
Okay. Let's go next.
What is the next?
Here we are.
Okay, clinical features of bowel ischemia that you have to operate on those.
Correct.
SMA dissection with SMA occlusion, type 3 dissection. Type 3 would
So
be
type 3. You know what type 3? We'll talk about it. Okay. But in
3 is
general,
the occluded through and false lumen.
SMA dissection with SMA occlusion. Do you have to do it?
No, completely occluded. That's it. The patient is depending on the symptoms now.
Symptoms, correct. But even symptoms, you have to be careful. Again, you don't rush, as we said. Depending how it looks. I mean, if it's occluded and then this study reconstitute, like this, our patient, then you can wait. But if you have dissection, SMA is occluded and no flow, and he has abdominal pain and he has sign of ischemia, you have to operate, So this is a tricky question. But in general, per se, just dissection occlusion is not an indication to have a symptom of compromised blood flow to the bowel. If there's no compromised blood flow to the bowel, you can still treat it conservatively, because you saw from our patient how remodeling happened after 42 weeks. So if you are patient, most of the times they resolve, but he has to be no bowel ischemia. But anytime you have a doubt of bowel ischemia, then you have to operate. Okay.
Okay.
Next one.
As a contraindication for anticoagulation. Momentary or intraoperative, you will give anticoagulation anyway.
Yeah, but there's no contraindication because you have to give him some
yes.
indication. If contraindication you cannot give him, then you have to stent him to get the blood flow. You have to store blood flow. So it's a tricky question. Again, go back everything to the symptoms and the ischemia. But anytime you have a doubt about ischemia, I think you have to interfere. This is the whole idea. Pain itself is not unless it persists for a long time. But this is the two major indications you need to do it. Okay.
Okay.
I see Martin here. Sorry, Martin, I didn't see you before. Martin, you have great experience with these things. Give us some input. What do you think about whatever we talked so far?
Can you hear me, Sam?
Yeah, I can hear you, Martin. Go ahead.
Yeah, I just came from the hospital. I just parked the car, guys. I didn't want to miss anything. I've just heard the SMA dissection part, and I agree completely with you to be conservative. This is very similar to the case we've been discussing today with the ESAM's case yesterday.
Correct. This is subject, so we can discuss it again. Yeah, with a fellow.
Yeah, because dissection is completely different playground than aneurysm. Many people are mixing it up. Sometimes you can even find they are talking about like dissecting aneurysm, but these are different pathologies and they behave differently. So this is what I've heard so far, but I'll be with you from now on. Okay,
thank you. You're right. Really, I mean, the rupture with the dissection is very rare. I think it's less than 1%. Most of the time you worry about the flow, not more the ruptures. The reason why, as Martin said, the pathology and the progress of aneurysmal dissection SMA is different from regular aneurysms, because the underlying is different, not the same risk factor. We talk about it. We don't know what caused it, but it's not the same as risk factor. And the reason why, as I said before, only 30% have hypertension, which is the most common reason for dissection. But in this one, is not hypertension. It's not what caused that. Connective tissue disease also is not sure 100%, because if connective tissue disease, why you just see it in this segment? Why you just see it in the rest of the aorta? So also we don't know. Again, the only theory they talk about it, the shared stress different. This is the only thing they talk about it, but nobody knows for sure. But the whole idea, we cannot apply the guideline from aortic dissection or aneurysm, second to the atherosclerosis on SMA dissection. It's completely different. The good thing about SMA dissection, it has a benign course. It's the whole thing you have to put in your mind. It has a benign course. Let's go about the type. Let's see if we can have the type. We can go over them before we finish. Let me see where's the type. Here's the type, guys. So in type, they look at the three things. They look at the lumen, patency, entry and re-entry, and outflow. So they call it A if both open, both open 2 lumen, entry and re-entry open, and outflow from the false lumen. If you have an outflow, right? Outflow from the false lumen present to a re-entry site. في عندك outflow to the false lumen. Type 1B, it's also both patent. You have entry, but you have no re-entry. But in the outflow, we have outflow through the branch. So we have outflow. So blood gain in and out. Yes, you have no re-entry, but you have a branch going out. So here, the outflow is the re-entry. So this is A and B. 2, you have an inflow, but no outflow. Okay? Whereas type 3 is thrombosed. No, sorry, type 2. Type 2B, you have no outflow, but the false lumen thrombosed. Here is patent. So this is different between 2A and B. And number 3, you have both thrombosed, but no entry or re-entry. Okay? So if you think about ours, which one is ours? I think ours is this one, 2B, right? We have a false thrombosed. This is open, and we have outflow. Now we have a thrombosis here. So I don't know, it doesn't fit any of these. Maybe it fit with this one because thrombosed. Yeah, I think we are 3. Because thrombosed distal, false, and we have thrombosed here and no entry. Yes, I think our case goes with a 3. This is a case you have to give anticoagulant here. Any question, guys, about this? Maybe you need to, I don't know if you get questioned in the exam about these types, but you need to review them, you know. 1, 2, 1A, B, 2A and B, and 3. Okay. Let's go to the last question. Here we are. Sorry. So question 8. Okay. Oh, the last question. Okay, go ahead. Who's there? Sam, you want to take it, Sam?
Yes. Which one is not correct among following descriptions regarding the late result of conservative treatment for patients with aortic with SMA dissection?
Okay.
Is not correct. Okay.
Not correct of these. Okay, so one by one.
Bowel gangrene is rare even in patients with SMA occlusion. Yes, this is correct.
Correct. We talk about it. We said most of the time you didn't get bowel gangrene because dissection. Okay.
Late onset of abdominal symptoms may be caused by ischemic bowel stricture. Yeah, this is correct.
Correct. Okay.
Yeah. Aneurysmal change is a common complication in SMA dissection patient. This is not correct.
Okay. Why is that? You know what? Give me like a number. You know, like roughly how often they get to aneurysm?
Maybe less than 5% even.
Yeah, that's correct. It's about 2-3%. So very rare. The reason why, as I said, they have a benign course. Already they get to aneurysm. Okay.
Complete remodeling of SMA can occur in about 1/4 of SMA dissection patients. Yeah,
Okay.
it's happening, but maybe it's more than 1/4.
Yeah. Yes, it is more. It's about already 50-60% they're remodeled. But the only thing here, they said complete remodeling. Remodeling maybe it's just 25%, he said, but partial remodeling is much higher.
Yeah, okay.
Because the majority is remodeled, like 60% are remodeled at the time. But not maybe completely, maybe partially. You still see stenosis, like what you see in the picture, you have complete remodeling, you still have a stenosis.
Stenosis. Yes, you are right.
You're still remodeling, but it's not complete remodeling, you know. So this is what you see in the cases. To see complete remodeling, like disappearance of the dissection, maybe 1/4 is actually the number. Okay.
Okay.
Next one.
Yeah, SMA remodeling can occur in patients with SMA occlusion.
Yeah, like our patient. So our patient, right?
Yes.
Yeah. So it can happen even if you have an occlusion. Like our patient has an occlusion and needs remodeling, you know.
Yeah.
occlusion because of the false domain compressing true domain. It's not usually not because of clot. You know, already you see a clot. It's occlusion because of compression.
Yeah.
So that the more is the time the clot to resolve, and you know the true domain will open up. You know, so you see more remodeling with the time. You know, so this is usually.
So the correct answer will be C.
Yeah. Yeah, we finished quick in this case. Any question about dissection, guys? Martin, want to add anything to the guide for dissection? But again, the only thing, guys, most important message: benign course, conservatively, unless you have a reason. Incidental finding, leave it alone. Don't even start anticoagulant. And majority of the patients is just too fun. Anticoagulant only when patient is in the hospital with the symptoms. But if he has an occlusion, we send him home with anticoagulant maybe for a couple months until we get remodeling. But if the force and both domain are open, is no clot, no compression, just dissection, and he's pain-free, I don't think you need to give anything to the patient. No antiplatelets, no anticoagulant. I think that's all. Okay, guys, we finished early today. Do you have just give me a suggestion? What do you like guys to talk next week or week after? What do you like to talk? We have like lower extremity, we have carotid, we have AV axis. What do you prefer? Any suggestion? Or give me a suggestion in the group. Somebody, you know. Maybe we can talk about carotid. We didn't talk about carotid for a long time. Or we go back again to the aneurysm or dissection. Dissection, we can talk about it.
Maybe carotid, doctor, yeah.
Carotid, yeah, it's a lot of controversy about carotid.
Please.
Okay, so let's talk next week. Maybe we can talk about carotid. It will be good to talk about it. Okay, guys, thank you very much. I will see you hopefully next week.
Thank you so much, doctor.
Take care, guys. Thank you, Martin.
Thank you, Dr.
Thank you, guys. Great talk, great discussion.
Thanks, man. Thanks, man.
Bye.